let's start again. More specific congenital malformation in case of fetus of diabetic mother will be sacral agenesis or caudal regression syndrome. Right. Now come to ways to prevent congenital malformation. We have discussed in the previous video that now the diabetes in pregnancy will be comprised of two videos. What I've asked, the half of the video I was discussed in the earlier one, and the next half will be covered in the next this video. So now let's come to ways to prevent the congenital malformation. What will be the ways? So obviously strict blood sugar control. Mother will be advised for that, including you will advise the mother for having supplementation. Folic acid supplementation should be provided in pregnancy early, at least 1 month before at least 1 month before planning pregnancy. Ideally तो ये 3 months before planning pregnancy होता है, but okay, you can advise her that started from 1 month earlier or before planning pregnancy. 400 mcg per day. Okay, now come to diet modification. There are some nursing implications in the gestational diabetes mellitus patients. So as a nurse, what you will advise her? So you will obviously advise her to focus on her diet. So her diet will be comprised of what? Now her diet should be comprised of, let's divide, 40 to 60% of carbohydrate. I've denoted it as CHO. 20% of protein, 30% of fat. So saturated fat will be less than 1% and unsaturated fat will be encouraged. Unsaturated fat will be encouraged to have, because example, in unsaturated had fish liver oil, that is beneficial for babies. Babies development, babies neurological development as well. So saturated fat should be taken below 1% and unsaturated fat should be encouraged for taking. So 30% the diet will be comprised of 30% of protein, 20% of fat and 40 to 60% of carbohydrate. Now in terms of calorie you have to advise, then the diabetes mother will have to take 25 to 30 kilocalorie per kg per day, and non-diabetic mother will be encouraged to take 35 to 40 kilocalorie per kg per day. So in diabetic, if the mother is obese, then she can take 1200 to 1400 kilocalorie per day, and if the mother is non-obese, then she can be encouraged to have 2000 to 200 500 2000 to 2500 kilocalorie per day. So in case of diabetic, that will be 25 to 30 kilocalorie per kg per day, and in case of non-diabetic will be what? 30 to 50 kilocalorie per kg per day. Further differentiation, further specification I have made that if the diabetic mother is obese, then she can take 1200 to 1400 kilocalorie per day, and if the mother is non-obese, if the diabetic mother is non-obese, then we can increase it up to 2000 to 2500 kilocalorie per day. Now obviously mild exercise should be encouraged. Exercise, self monitoring of glucose, HbA1c level, as I have said, because HbA1c is a prospective and retrospective test altogether, because it also tells us about what is the sugar level, what is the sugar level before 3 months, and that's why it's called retrospective. And prospective is why I have called it prospective one too, because it also shows us the value after 3 months. Okay, so HbA1c should be started, the mother should be started from last of the first trimester. The mother should first trimester, last of first trimester, the mother should check her what na HbA1c level. Then from 3 months onwards, actually last of first trimester onwards, then 3 months gap she can maintain over a 3 months gap, because HbA1c is what telling us about 3 months the status of the blood sugar level on a 3 months gap. Now infection, obviously we should inquire her about infection, because she is a gestational, be it a gestational diabetic 1 or a over diabetic 1. In case of over diabetic 1, so we should have to ask. So in case of both, we have to generalize that we have to inquire about, because diabetic will lead to what infection. So inquire the mother about what? Now inquire the mother about UTI or vaginitis. If the mother is having this, we have to inquire her about that. Now including daily fetal movement count from 28 weeks onwards, because there are chances of abortion. Okay, abortion happens when less than 20 weeks of gestation. Then IUD happens when more than 20 weeks of gestation, and these are common phenomena. Stillbirth, increased chances of stillbirth as well at the time of delivery. So there are increased chances of abortion or IUD, you can say. So we have to tell the mother that she needs to check the daily fetal movement. That's why it's being called daily fetal movement count. So from 28 weeks onwards, the mother will be advised to lie lateral on the left side, and lie lateral on the left side after 1 hour after major meal. 1 hour after major meals. Major meals in what? Okay, including in case of pregnancy, that I have tell you that the diet modification, you will add one point also, that the mother should have 3 major meals and 3 minor meals. And what do we mean by major meals? Major meals is what? Major meals is breakfast. Major meals are what? Major meals are breakfast, before breakfast, lunch and dinner. So from 28 weeks onwards, mother will be advised to lie lateral on left side 1 hour after the major meals, be it breakfast, be it lunch and be it dinner. So after breakfast, after lunch and after dinner, the mother will be asked to lie on a lateral position on the left side for 1 hour and try to count the fetal movement, because after the 1 hour the fetus will be getting the food from the mother, so there will be a movement. While having the food, the fetal will cause some movements, so the mother will be asked to count the fetal movements. The normal fetal movements will be what? Now normal fetal movements will be 10 movements in a 2 hours rest, or 10 movements in a 12 hours of activity. So mother will be asked to maintain a chart of that. Okay, because if the fetal movement is less than what is supposed to be, so she should immediately report to her doctor or her nearby clinic, antenatal clinic. Now in case of including, the mother should have to undergo what? Now should have to undergo what? TIFA, that is a level 2 anomaly scan in at 18 to 20, level 2 USG at 18 to 20 weeks. Then from pregnancy, diabetes in pregnancy is a high risk pregnancy, so from 28 to 32 weeks, the mother should also have to undergo NST, that is a non-stress test, and biophysical score weekly. Okay, now Delivery in case of a diabetic mother. When the delivery should be initiated? Ideally 39 to 40 weeks. Mode of delivery should be what? Vaginal, obviously. And if we say cesarean, we can also carry it, but there will be some certain conditions when we will have to carry out cesarean section in case of a diabetic mother. When if the baby is weight more than 4.5 kilo, that is a condition of a macrosomia, we can carry out cesarean section. Now complications of the diabetes in pregnancy, I have categorized into 3: maternal complications, fetal complication, then the neonatal complication. So start with maternal complication. So if the mother is diabetic, hyperglycemia, maternal hyperglycemia, then what will it lead to? Fetal hyperglycemia, fetal hypoglycemia. So fetal hyperglycemia, if there is fetal hypoglycemia, so fetal will produce what? Increased urine, because in case of hyperglycemia we have see that polydipsia, polyphasia, polyuria. So in fetus it will be the same. So fetus will what? Polyuria. Fetal will produce what? More in urine. Then polyuria will cause what? Polyhydramnios in mother. So polyhydramnios in mother can cause multiple complication. Polyhydramnios can land up into premature rupture of membrane. Polyhydramnios can land up into preterm labor. Polyhydramnios can land up into PPH, okay, or abruptio placenta. Maternal hyperglycemia is also prone to what? Infections. So infections also can lead to preterm labor. Okay, so these are the including the maternal in case of a diabetic mother, increased chances of PIH, pregnancy induced hypertension as well. So these are the complications in a diabetic pregnant mother actually. Now come to the fetal complication. What will have? So if there is fetal maternal hyperglycemia, so fetal will produce what? To combat that, fetal will produce more insulin. So insulin is responsible for what? Growth of the fetus. So when the growth of the fetus increase, the condition will be termed as macrosomia. Including macrosomia, there will be deposition of fat around the shoulder as well, and the condition is called, I have discussed you in the previous one also, that previous video also, that is called shoulder dystocia. So again there will be problem in delivering the baby. Okay, now come to the neonatal complication. So what will be the neonatal complication? So just we have read that preterm labor can be, the baby can land up into preterm labor. So when the preterm labor, so baby will be immature baby, we all appreciate that, immature baby. So immature baby will have what? Immature lung. So it will lead to what? Respiratory distress syndrome, right? Including what happened when the baby is in the mother's fetus. So there will be fetal hyperglycemia. Now the umbilical cord has been cut. So during the fetal hyperglycemia, fetus has started producing the insulin. Okay, now after the delivery, the umbilical cord has been cut. Now the raised insulin will work upon what? So if the insulin gets raised, because you have the raised insulin have already combated the hyperglycemia that was in the mother's fetus. Okay, so after the umbilical cord has been cut, the insulin still remains raised, okay, to combat that hyperglycemia. But between the connection between the maternal and fetal, wait, I'm making you understand again. Maternal hyperglycemia will increase what? Fetal hyperglycemia. Now if the to combat that, what the fetus will do what? Now increase more insulin. So now after the delivery, the umbilical cord has been cut, so there is no connection now between the mother and fetus. so it has become the neonate. So but the insulin remains the same. So in raised insulin will do what? Will do hypoglycemia, because unless the mother is giving glucose to the baby, so from where the baby will supposed to have that glucose, right? So the insulin will remain increased in the fetus, and there is no insulin to work up, and there is no like blood sugar the insulin will work upon. Okay, so increased insulin will be in the neonate, and that will land up into hypoglycemia in the neonate, including there will be hypokalemia, that is decreased potassium, hypocalcemia, hypomagnesemia, including the neonatal complication. There will be what? Hyperviscosity syndrome. So that's why it will end up into polycythemia and hyperbilirubinemia. So this will all, so this neonate in a diabetic mother will all have this. So these complications that I have written, the neonatal complications as the neonatal complications, so the baby will show all the complications I have written in a neonate in a diabetic mother. But neonate in a diabetic mother will not have anemia, will not have any mental retardation, will not have hyperglycemia, right? Including there's another point I want to add, that is gestational diabetes termed as white, gestational diabetes mellitus termed as white classification. Gestational diabetes mellitus has been classified as white classification. So which gestational diabetes has been controlled with dietary modification, that will be termed as G1, that will be termed as A1, and the gestational diabetes mellitus that is not controlled with dietary modification, that is being controlled with insulin, that will be termed as A2 classification. So including, I want to add one point. In case of gestational diabetes mellitus, in the previous video I have said that there will be certain dietary modification you have to make, or you have to advise the mother. So if the mother is if the mother maintains that the range, actually the range should be, in case FBS 95, RBS should be more than 140, and PPBS, right, and HB1C less than 6%, 200. In case of over diabetes, though, I have discussed that it should, FBS will be more than 126, RBS will be more than 200, and HbA1c more than 6%, less than 6%, more than 6.5%. But in case of GDM diabetes mellitus, gestational diabetic mother, the range should be set between this, that you should maintain